you feeling like a flow?
Good afternoon, dear colleagues from all over the world. I would like to thank you for this great opportunity to the botiss team and also to the technological team to give me the opportunity to talk to you and to share with you some of our experiences as clinicians in terms of bone and soft tissue grafting. I send you greetings from a small city in Germany named Baden-Baden, where we work together with a team of specialists and try to reestablish an emotional smile, an emotional beauty. Therefore, implant dentistry and dentistry generally, I think you agree, you see that it's more and more a symbiosis between art and science. It has an emotional component. It is a symbiosis between all the technologies and the studies that we have, when we read, the literature, and the way we implement this knowledge in our daily work, in workflows, which makes our treatment more predictable, more minimally invasive, and at the same time maximum of aesthetics. Actually, this is also my message to you today, or my message of my lecture should be the way we take, or we try to take from the literature, from the studies, from experience, from that what we know that it's functioning, and implement in the daily workflow in order to give the patient the maximum of aesthetic on a minimally invasive, maximum effective way. We start always with an aesthetic analysis and a functional analysis, and we use all the techniques and technologies, digital way of showing the patient the way she or he will look like, and then put our work together in a systematized, organized workflow to get to this wished result. And the topic today is not necessarily the white aesthetic, therefore I would like to take my definition to that, perhaps in a future one. But the pink aesthetic is this tissue which is so challenging, and at the same time this frame that surrounds this white beauty. And we know that even a natural tooth needs a certain bone contour and a certain health and beauty, color, structure of the periodontal tissues. But how much keratinized tissue needs a tooth? And let's stop here for a moment. From Lang and Löhe, we know from studies that all teeth that have a keratinized gingiva more than 2 millimeters, 1 millimeter attached and 1 millimeter free, is healthy. Now, everything else which is less than 2 millimeters has signs of clinical inflammations, recessions between 0.7 and 1 millimeters, especially when is in combination with a crown margin. Now, we used years and years, or since years, connective tissue graft. Since 96, it starts more and more to be used, one or another membrane in a localized buccal recessions with good results. What else do we see in studies in the last time? That, and let's stop here a little bit, that even if you use PTFE membranes, like non-resorbable membranes, the result of the recession treatment is actually the same as with connective tissue. What else do we learn from the literature? That when you use in the GBR technique alloplastic materials, they are more responsible for repair, the allogenic and the autogenous bone more for regeneration and formation of new attachment. What else we know? When we use a membrane, for example, for the furcation covering, the result is much better when the initial thickness of the tissue is more than 1 millimeter, which is logical. So now we implemented those membranes and we started to use it in certain mucogingival surgeries, like a semilunar flap, like a coronally advanced flap, and with very good results. So we have today, that it's the question which membrane we take and why. Now, at the beginning, and I have to talk out of my experience, I noticed that some of the membranes, collagen type 3 to 4, long resorption time, a kind of sponges, a kind of soft structure, seems to increase the quality of the soft tissue after the implant placement. I was using the membranes for covering the grafting. Now, we see now more and more that the structure of the membrane is in a direction of a matrix. That, let's go again back a little bit. And the resorption time is long, 6 to 12 months, give us the possibility to cover with this membrane also the grafting. And when you do a biopsy after this grafting of the soft tissue, or also of the bone grafting, you don't see any membrane. Is a complete remodeling of the membrane. You see also a good vascularization of this membrane in the moment you implement it in the tissue. And an easy handling. So those are tissues or membrane which we use today to implement and to increase the thickness of the tissue. The thicker the membrane, the thicker will be also the tissue afterwards. Of course, you can implement your procedure with enamel matrix derivate, who seems from the studies to increase the proliferation, migration, adhesion of all the cells which are part of the attachment. This is, for example, a case of Zucchelli, who also solved extreme cases like a class 4 Miller with those combination. Now, the procedures in plastic surgery will be more and more minimally invasive. Even if you take on the left side, let's take this, on the left side, a connective tissue graft, we use a tunneling afterwards, which is a very elegant method, which we learned from Salama, from Sadoun. I love the method of Homazadeh, the Vista technique, which is some vertical incision, and it allows us to bring the membrane very nicely into this pocket. Or even if we need to cover the recessions a little bit more than we do, what we learned also from Zucchelli, and coronally advanced flap with a double split technique, and a split a deep one and a superficial one, and one at the time of the papillas. And we cover the membrane that we implement there in a way that everything is out of tension, out of compression, out of tension. Today I will put first a horizontal matrix suture first in order to fix this flap, and then I will do the rest of the procedure. So therefore, we use more and more minimally invasive procedure with good results. The secret of success in a coronally advanced flap, in order to not to have dehiscence and to have the cover recession, is to fix this flap on the crown, or to cover the crown of the teeth in a certain procedure, like you will see in the next picture. So all these procedures with membranes we use in the last years with success in plastical periodontal surgery. Now, what do we do in implant surgery? There are here also key factors to assure us a good bone volume and architecture, a soft tissue thickness which we need, and we will see how much we need, and also a position of the implant which we need then to be certain in order to give us a better aesthetic result. Now, concerning the single tooth implant, we have some coordinates and some rules which we have to respect concerning also grafting. There is a philosophy of grafting which we follow in implant dentistry, which was developed also or where we learned a lot from the plastical periodontal surgery. So when you do the first group, when you treat the first group of ideal sockets, you are allowed to insert the implant, to do an immediate implant placement, immediate loading, but at the same time graft the gap and graft the soft tissue because the surgery is tissue thickness oriented. With what? With connective tissue graft. You can do here a connective tissue graft or a membrane. Now, when you're missing buccal plate until 3 millimeters, you still can do an immediate implant placement, graft the defect, graft the soft tissue, but don't do an immediate loading because the aesthetic result will be less good as that. Let's stop a little bit. And the grafting of the soft tissue will be not necessarily with a connective tissue graft. It will be rather with a membrane because we need to cover this defect. And the connective tissue graft will be part of the tissue, but also part of the graft. So we'll diminish the volume of the grafting which we do. Now, if we don't have a buccal plate, which is the category 3, or it's missing in a big part of it, then we can use under the condition that you don't go out of the envelope of the bone, you use a sandwich technique described by Homely Wong. But we know lately from Tarnow that even if you put some granules there, you will never find granule on the surface of the implant. You will find bone. Or when you don't have interdental bone, you go 2 stages or 1 stage. The criteria we will discuss it a little bit later. Because until 5 millimeter missing of a vertical bone, you can do particulate materials, as you will see later on. But we don't even know, and let's stop a little bit here too. We don't even know which is the method to graft a socket in order not to lose any volume. Sometimes it's better, or even if the socket is intact, or more when the buccal plate is missing in certain proportions, to graft a socket and then to go by a smallest tissue punch like 2 millimeters, like you will see later on. Now we have to stop here too. Now we agree from all the literature, and we argument that to the literature later on, that we need 3 millimeter of tissue thickness, 2 to 3 millimeter tissue thickness around implants, 3 millimeter tissue height around implants, and we will see why, and 3 millimeter of keratinized tissue. Keratinized means attached and not attached gingiva cells. That's why we need 3. And this will give us a natural and constant and stable bone volume underneath in the height and in the width. That means that in very many situations, more than in the natural dentition, we have to change the soft tissue biotype in order to have a stable situation of that implant. We have to prevent the peri-implantitis and to maintain it. And this thing was mentioned already by Berglund and Linde, that there has to be a gingival cuff surrounding the implants or abutments. And nowadays, when you insert the implants below the bone level, sometimes this gingival cuff, the collagen fibers, which are running parallel and not perpendicular, are surrounding not the implant, but the abutment. The junction epithelium is more coronally. We know that 0.5 to 0.9 millimeters of recession will be at a facial marginal mucosa in majority of the situation after implant placement. So therefore, we want to prevent that. How? We insert to the right position of the implant, which is 4 millimeters from the buccal margin. We graft this gap, we graft the soft tissue, because a buccal collapse, which is more than 1 millimeter, will give us also color difference, which we know from Stephen Drew, Dennis Tarnow, and so on. We know from Linkevicius, let's stay a little bit here, that the implants with platform switching design, they conserve the bone. They will lose 0.6 instead of 1.4 to 1.6. But Linkevicius shows us that even between 2 implants with platform switching design, you will lose bone if you don't increase the tissue biotype, if you have a thin tissue biotype. And this is the same thing was confirmed by the study made by Atlanta team and the New York team and the South American group, where it's shown that in the bone zone and in the tissue zone, you have the less of volume loss. If you do an immediate implant placement in the extraction socket, immediate loading, grafting of the gap, grafting of the soft tissue, a provisional abutment which you change only once, and a provisional crown. So this is the ideal situation, the ideal treatment, which gives us the less of the volume of the tissues. Even if collagen collapse anyway, because it's not the same structure. Now we learn also from Gargiulio from years ago, through the building of biological width, and also nowadays from Linkevicius, that if you have less than 2 millimeter height of the tissue around implants, you lose 1.5 millimeter of bone. If you have more than 3 millimeters, you don't have bone loss. This is the argument, or those are the arguments to have 3 millimeter of tissue height around implants. In addition, if we have a buccal lingual collapse of more than 1 millimeter, you have additionally discolorations. Additionally, we always, I will stop here, the abutment, on the abutment will be always a plaque adhesion. So even if we clean and steam it before insertion, afterwards we have plaque adhesion. And plaque adhesion means that you don't have bleeding. That it is a zone behind bleeding, and this plaque adhesion will be between 0.5 to 1, even 1.5 millimeters. So you lose out of this tissue height from 3 millimeter, 1 millimeter already. So you need here the 3 millimeter in order to have a certain bone adhesion, a certain adhesion of or adherence of the tissues or of the collagen fibers. Therefore, the positioning of the implant 3 to 4 millimeter below the free gingival margin that we want to achieve is necessary. So this assures us an health of those tissues and the conservation of the bone underneath. So that means that everywhere where you have, when you don't have adherence and bleeding, the volume won't be staying. When you have adherence and bleeding, then the volume will keep staying. Now, this is the ideal position in ideal intact socket, palatally from the socket, until 4 millimeters from the marginal buccal plate or gingiva, grafting of the gap and grafting of the soft tissue in a split thickness technique, in an envelope technique, which leaves us the papillas intact and the bleeding intact. So the split thickness flap will be the best. So that means that we have a tissue stability which we have to maintain, as you see here. So that tissue stability is, well, after we created the soft tissue, we have to hold it in the same place. And you see, if we have minimally invasive procedures, we have the chances to have this height and thickness of the tissue around implants. Now, this article came lately, and I was very happy to see that a technique that we use in the office very long, meaning a concave profile of the running room or of the emergence profile, was documented by Carlo Majorana in terms of maintaining this volume on the long run. So first we create the tissue around and then we maintain it. For example, I always insert 4 implants, adjacent implants. I don't do bridges in order not to lose any volume of the bone, especially when the patient is young. And also from hygiene concerns, I use a connective tissue graft or a membrane in order to increase or implement the tissue quality, as we learned, and concave profile of the healing abutments or of the provisional abutments. So you can see the difference of the profile of the tissue in the left side and on the right side. So we use all this tissue on the right side in order to conserve the bone underneath and also to build a papilla. Now, you see on the left side, platform switching design, less bone loss, 0.6 instead of 1.4 or 1.6. So we gain supracrestal fibers, which are more coronally. Additionally, we have concave profiles of the provisional abutments which can be changed in a statical zone in a slight convex profile, which pushes our tissue another 0.5 to 1 millimeter between those crowns, respectively the implants. So you can stay with a concave profile of prefabricated abutments in the lateral zone. You will have a good gingival cuff, as Linda was saying and Lang was saying, but in the aesthetic zone, when you will need an additional 0.5 millimeter of the papilla, you can change the concave abutment in a slight convex profile afterwards. So when you see it in the clinical case, you see that slight convex profiles of the abutment zirconia on titanium made CAD/CAM individualized will push this tissue in between the abutments. And additionally, we take we make the crowns, like as we learned from Tarnow, specific to the tissue typology, 42 to 43% of the interdental space is the contact point. So we keep those triangles between the crowns narrow. So we have then this papilla will stretched in this triangle with the time. And don't be upset, because we need 6 weeks at least for all this tissue to heal. Thank you. To heal and to mature. So don't be upset if you see this black triangle after you inserted the crowns. In 6 weeks it will be implemented. 6 days for gingiva, 6 weeks for connective tissue, and 6 months for bone. So I do this compressive technique, not with the provisional, with the final one. After all the grafting and all the maturation of all the structures afterwards are done. Now, when this is group 2, when we have a small defect of the bone, which is until 3 millimeters, like in this case, when the single tooth has an apical defect, what we use here? We don't necessarily use a connective tissue here, we use a membrane. We do an immediate implant placement. We graft the gap, and we graft this also with an envelope technique, the soft tissue with a membrane, which has a property to increase the quality of the tissue. Collagen type 3 to 4, long resorption time. And in order not to lose any volume, we don't do in this case an immediate loading because it is a defect there. We do a late loading, and we do, in order to have the maximum of the volume, either an onlay graft or an connective tissue onlay plus onlay graft, depending on the situation. But we use the membrane to cover the defect, and then we use this onlay graft on the top, and we use a membrane depending on how much tissue thickness we have to gain. Now, you have to take into consideration to keep 1.5 millimeter from the neighborhood teeth in order to assure a vascularization to avoid some necrosis of this onlay graft. And this is actually what I use always when I need 0, when I need the less loss of the volume, so in a statical zone. Now, the membrane that we use, we should always look after the properties, because this will be confirmed clinically. Therefore, we use membranes which shows after 3 days, 15 days, 30 days, already a sign of vascularization, and we see the purity of this membranes. You see already after 30 days connective tissues penetrating through, and after the full metabolization, you don't have any membrane parts into the tissue histologically. And both, even if collprotect, for example, is a membrane which resorbs faster, you can still have this property, because you see that it holds his volume after 30 days after implant placement. So the criteria for membranes To graft the soft tissue should be purity, fast vascularization, keeping the volume after a certain time, a long resorption time, then you can use it also for covering the graft, and a good handling of those membranes. Now, in the case before, we use, as I said, not a provisional crown on the implant, is an Maryland bridge, and after the healing, this is a kind of bleeding of the tissue underneath the bridge, you see, before of kind of a small inflammation, and uncover will be with a small tissue punch. And there is a study of, let's stop here, of Dennis Tarnow and Stephen Chu, a study, an article which shows that in very many cases this tissue punch technique is much more protective, is much more minimally invasive. I use only the 1.5 to 2 millimeter tissue punch, only to remove the screw. And my impression coping is made in a way that it takes only, it doesn't compress the tissues. Now, the abutment will be done also in a CAD-CAM technique, a white abutment, in order not to have any discolorations of the tissue. And you see, well, using the tissue punch for uncovery is also avoiding any vertical grafting or vertical incisions. Therefore, also sometimes we have to consider the socket preservation and then the insertion of the implants with the tissue punch. And this is the situation of final situation with a final crown, and you see that the recession, that the quality of the membrane is, or quality of the tissue where we inserted the membrane is even better than at the contralateral side where we have a recession. So we give ourselves a note 9 to 10 for the pink aesthetic score. And this is actually a subject of the study on 500 implants, which we did in the last time, respecting those parameter coordinates which we talk about today. Now you see, and vertical incisions are always anesthetic, and we avoid to do it if we can do anything else. So just learn what is, or think every situation and take the most minimally invasive procedure from the aesthetic point of view, but also from the surgery's point of view. Now, those vertical incisions are there and they don't disappear because the gingiva has no elastic fibers like the skin, so they will always be there, so avoid them if it's possible. Now, category 3, no buccal plate, no implant. Well, if the implant doesn't go out of the contours of the bone, of the envelope of the bone, then, and respecting the flap advancement, flap design, far away from the grafting, flap advancement techniques, different techniques. Take care of the vascularization of the flap, enough bone potential with all the techniques that you know, or there are more than one technique. No pressure, no compression on that flap, then, and the graft stability, then this kind of big grafting with or without implant will be successful. Now, the first condition is to create a space. This membrane or this tool that you use, it has to to maintain the space and the immobility of this graft. And what we use in this case is a tooth which, after the extraction, creates a horizontal and vertical defect. And we use a polylactid membrane which is stiff. You can use mucoderm too, as we saw lately from one of our colleagues, and fix it with polylactid pins. And this space which you create there, it transforms this defect in a 3 bony wall defect. Now this membrane will resorb until 1.5 years, and this place will be grafted with a bone material plus autogenous bone. Now I have more experience with beta TCP plus HA, so Max Resorb is my favorite because I noticed and I read from studies that is influencing the vascularization and growth factors, because there are some trap-positive multinucleated giant cells there. So covering this polylactid membrane with a collagen membrane in order to increase the soft tissue quality gives us this result after the inserting the crown and after a while. Now, when interdental bone is missing, we need also a method. We have situations when we can work with particulate materials or not. Now, it's everything, the success is depending on the incision flap, design flap, advancement, graft, suture, as you know. And this time, well, today I wouldn't do this vertical incision anymore, but that was the case at that time. This is a tubing implant, a ceramic implant, and an apical process. We extract both and insert two implants, and use the same polylactid membrane, because the defect which we create there, the defect that is created there is vertical and horizontal at the same time. And we use this polylactid membrane to create again a 3 bony wall defect, the healing cups of the implant, and we fill this space with beta TCP and autogenous bone. Cover everything with a collagen membrane and use a Maryland bridge as a provisional. Okay, we will have to see the provisional result as in the form of a Maryland bridge in a minute, and then the final result after we did a crown lengthening on the laterals in order to re-establish the zenith of the gingival part. The condition of the successful grafting is taking into consideration the quality of the host bone and the architecture and the size of the defect. If it's a socket or a defect, the more bony wall you're missing, the more bone potential and you have to bring or you have to take care of, and the more vascularization has to be there in the first 2 minutes. So therefore we use the PRF technique, membranes, which we use it in combination with the bone materials and autogenous bone, but also as a membrane on the top of it, and we will see when. Well, the APRF has neutrophils in the last segment, which promote the proliferation from monocytes into macrophages, which give us a better vascularization in the first 2 weeks of usage. So this implements in vitro as at least the situation, and in vivo also. Now, I use a recent article shows that when a combination of beta TCP, HA, and PRF accelerates the metabolization of the beta TCP and the build-up of the bone. So the situation before, which I mentioned, is a collagen membrane on the top of that it's grafting and close the flap. You see, it is over-dimensioned, over-augmented. And we use a Maryland bridge, which we model more and more in the meantime. And at the end, when, as I said, we change the shape of the gingival zenith, and we have this veneers at the end and crowns at the end of the story. Now, this vertical augmentation at the same time with the implant placement can be done when the vertical bone missing is approximately or 4 to 5 millimeters, and you have a vertical, a mesial and a distal peak, bony peak. Then you can insert those implants, transform this defect in, with the polylactid membrane in a 3 bony wall defect, fill this gap with the graft material or autogenous bone, allogenic bone, whatever you consider that is necessary concerning also the quality of the host bone, and cover all this with a collagen membrane, which we use today, collagen membranes which are prone to have the quality to increase the quality of the soft tissue at the end, because that will protect our grafting, A, and B, will give us a good quality of the tissue afterwards at the time of the implant placement, of the uncovery, and give us tissue to manipulate through the prosthetic parts. Now, for example, okay, we go a little bit further on because we don't have so much time as we'd like to. So this technique will be used also in, for example, in situation where anything else or anybody else will do perhaps bone grafting procedure. Well, the OPG before was here, frontal teeth. I cannot show you before because then jumps to the other part. There are immediate implant placement and immediate loading. On the lateral jaw was a situation where we had a mesial and distal peak, and normally we would do bone grafts. So we insert the implants, as you see here in the pictures, on the right and the left side with the sonic well technique, and in the frontal area an immediate implant placement, immediate loading. We use this technique by building up the buccal plate and covering with a collagen membrane in order to give us a stability of the soft tissue and a certain thickness of a soft tissue. So from the situation with frontal teeth to extract, no lateral teeth, we have a situation where the patient goes with fixed teeth home and a good volume of the bone and a good quality of the soft tissue. In full arch reconstruction, we have rules which we learned from Carl Misch, and we know that we can have an immediate implant placement, immediate loading. We have perhaps an FP2 situation when we have a vertical loosening of the bone. So the teeth which we do on implants will be a little bit longer. Or we have an pin component or an FP3 where we have a removable. Now that means that we have strategies concerning the fixed construction in full arch restorations. That means we have the first strategy where we go for preservation. So we don't have intact sockets. We insert the implants in the same session. We graft the sockets. We graft also the soft tissue. And the strategy 2, when we need to raise a flap because we have buccal defects. So we work with membranes there. We have bony and tissue reconstructions with the implant placement. The strategy 3 needs prosthetic reconstruction of the pin component. That is when we cannot build up all the papillas and all the vertical dimension that we need in order to give a profile. So you need to do a pin component. And the fourth strategy is when we use other dental procedures to get to from the strategy 3 to the strategy 2, for example, to reduce the invasivity of the treatment. Now, the strategy 1 is, for example, the situation when we do immediate implant placement, immediate loading. This is in intact sockets, the way you saw in a single socket. We will do it in a full arch restoration, for example, in this case. Now, this is also perhaps an opportunity to discuss and an opportunity of different opinions, because all the full arch patients are perio patients, and there is always the question, when do you extract a tooth and put an implant? So the consensus between a perio guru and an implant guru should be when the perio situation is after all the treatments presenting mobility and inflammation after 1 year, and the vertical bone is less than 10 millimeters, then you should extract a tooth and put an implant. And when we use the photodynamic therapy in order to decontaminate, which is very successful in the last 2-3 years, and studies are showing very good results, decontaminating the sockets, we do an immediate implant placement also in perio cases. So you see here a situation after healing in the middle, and following the protocol which I described before, concave profile of the provisional abutments and slightly convex profile of the final abutments, which is this time Emax on titanium base, assures you a very nice aesthetic outcome, which is there over years. And I'm always thankful to my technicians because The smile is theirs, not mine. You see those crowns which have such a nice design, and the contact points very naturally. There is a certain compression of the abutments, but the situation is stable over years, and you see the amount and the quality of the keratinized tissue when we work after the procedures and with the materials which we know that they are functioning predictably. Now, the FP2 situation, or strategy 2, means, oh, this is another situation, an FP1 situation or a strategy 1, which was the same, but at that time I didn't take very much into consideration changing the tissue biotype. So the result is not necessarily very symmetric. Now, strategy 2 means we have to raise the flap. So we have a patient with also perio patient, and we use, as I mentioned at the beginning, the designing of the smile with digital smile design, so we are able to show the patient the way she will look like at the end. And then on the hand of the wax-up or of the mock-up, we'll do a provisional in advance and an aesthetic guide. So we insert the implants by raising the flap, grafting all these defects, and covering everything with a collagen membrane with the properties which you know. Here is also in the vertical defects will be covered also with the polylactic membrane if it's necessary. So in the same session, taking care of the right flap advancement, we managed to do an immediate loading, collagen membrane on the top of it with the long resorption time, and giving us the possibility to increase the soft tissue quality. So therefore, we have at the end of the case, well, either we prepare this abutments, or we take abutments which, when the implants are really parallel, then we will leave it like this, and we don't change those abutments even at the time of impression taking. Then the situation will be like following. So that is the provisional, which is made in advance in the form of a shell, and if the implants are parallel, then we have caps to put on that situation, and we will use also into the bone grafting growth factors. The bigger the defect, the more we have to take care of the vascularization in the first time. And this grafting will be, or this PRF membranes will be inserted also into the graft materials, but also used as a membrane on the top of it. And how do we use that? You will see in a few seconds. We use also a little bit clindamycin into the bone grafting, because that doesn't come from me, it comes from Carl Nisch, which taught us that you avoid the inflammation. After the impression coping, you see that the impression coping are on that abutments which will be provisional. So this is the stable situation of the bone and of the soft tissue on the long run. This is the clinical situation of the situation, and you notice the very good quality of the gingiva, of the keratinized gingiva around the teeth and implants. Now, we have to think how we use those membranes and how we use all that we have. Sometimes I don't need a buccal grafting because it is enough bone there. Then I use the PRF membranes only to increase the potential, the vascularization in terms of increasing the potential, the healing of the soft tissue. Then we use membranes which have perhaps not such big thickness, depending on the necessity of increasing the soft tissue thickness around implants. We prepare those membranes with an rubber dam instrument and cover the grafting, and which is underneath. In the grafting, we mix, as I said, PRF and a little bit clindamycin if you see that is, or if it was a perio case, which is mostly the case. Then you cover all those abutments, and you will have a nice situation afterwards. Okay, now the flap advancement and having no dehiscence is, of course, is another issue, and we will see in a minute how we approach in order to give us a better quality of the keratinized tissue. When we need a very thick quality of the tissue afterwards, then we use the mucoderm membrane also to cover the grafting and to increase the quality of the tissue. The capacity, the hydrophil capacity is there, so you use the blood or the product, the plasma, which was used for, which comes from the PRF. And you see this situation after you cover it and after the healing. So you see which is the quality of the tissue that you gain when you use mucoderm as an grafting of the site, soft tissue and bone at the same time. So those gives you a very good predictability on the long time. And this is actually the subject. Those all are procedures and techniques which we used in this study in the last 2 years. And this is a split mouth technique of suturing. Right is a continuous suture with flap. Left is a horizontal and vertical matrice suture. And you see, using this horizontal suture at the beginning, we fix this tissue. We have to stop here. We fix this tissue on that implant, and what we notice is that we gain at the end of the day more width on keratinized tissue. That gives us, on the other hand, no compression, no tension. And which is, well, no compression, no tension means the vascularization won't be damaged. So the healing would be better. And on the other hand, no compression, no tension means that you won't have any dehiscence on that side. And this is a kind of suture or philosophy which you should use no matter what kind of soft tissue manipulation you do, in order to think, to treat those tissues with respect, with gentleness, and think always about the vascularization of their tiny, potential of destroyment. Now, the bone splitting is another very nice procedure of strategy number 2, where we gain the bone through bone splitting, inserting the implants into that splitted situation, splitted jaw. The single condition is that you put the implants in the right position buccal-palatally, but also distance from each other. Therefore, we use some silicone key or some aesthetic device which guides us in the implant placement. And if everything is done properly, then we will have a nice situation of the tissues, covering everything with the membranes, which have the same quality. You see the hydrophility and max resorb, as I told you, that is beta TCP and HA. This is the material which I use since years. And we have, after the healing, first the provisional put in advance, and after the healing, and long-term keratinized tissue, which you see already in the time of the healing, but after the healing is more clear. We do, in this case, titanium bases with zirconia abutments individualized. The margins of those abutments are 0.5 millimeter under the gingival or under the zenith of the teeth that you want to achieve, or the crowns that you want to achieve. In such situation, it's better to cement with quartz, and this is actually the situation on the long run. Again, very nice work of Mr. Dannenberg, one of our master technicians. Now, the strategy number 3 is transforming. Well, this is all these cases were including also the strategy 3 and 4, which we'll show you in a few minutes, is a part of the retrospective study makes in the maxilla and in the mandible using beta TCP and HA, allograft plus allograft if was necessary, a membrane with the quality to increase the soft tissue quality. In 85% immediate implant placement and immediate loading, and you will see the results at the end of the lecture. Now, strategy 3 is the situation when you need pink component. But even if you need a pink component, you have to take care of the bone and of the soft tissue, and because that is a question, that is a condition for a long-term stability, to even if it's not about the papilla. That includes also the FP3 when you do perhaps a removal or screw retain construction when the pink component is even bigger. Now, in this situation, which is also a perio case, you have a crown height space more than 12, between 12 and 15. We know that we need a pink component, so the situation afterwards looks like in the right picture. It is also a situation when we do graftings horizontally and vertically, in using also sonic weld technique and all the procedure that you saw before. We use mucoderm as an tool to protect the grafting, to protect those horizontal and vertical grafting and increase the soft tissue quality. We start always on one half in order to have an orientation about the direction of the implants, and then we extract the other teeth. And then we'll have the situation of the soft tissue, as you see here. Even if you don't need any papillas, but you have a healthy situation which guarantees on the long run, if the hygiene is also fine and the prosthetic is made in a way that it's cleanable, on the long run, as a nice situation. Now, a strategy 4 means that we use orthodontics, for example, to take the strategy 3 and strategy 2 and therefore, with the permission of Dr. Kobi Landsberg, I use his animation, Periodental Master, to show that first we can do an perio treatment, and then we can move it orthodontically after 5 weeks already, as he says in his last article, and then transform this situation in a strategy 2 when you don't need a pink component. And as you will see, the situation is with a little bit longer teeth, but still she doesn't need a pink component. We put the implants in the right position. Okay, then we have the position which we needed at the end. The provisional abutments, in that time it was prepared, and we have a final situation like this. We don't have pink component, we have a little bit longer teeth, but still she is satisfied. She didn't want some pink component, she would have shown that by her smile. So now, including all these cases, we have a success rate, well, we're using implant systems with a good primer stability, using graft materials and the techniques of grafting of the bone and of the soft tissue which you saw before, have a pink aesthetic score which is 8 to 10, so good aesthetic results in 100% of the cases. Width of the keratinized tissue, which is more than 3 millimeter in 87.6% of the cases. Okay, we have a thickness of the keratinized tissue of more than 1 millimeter in 91% of the cases, and no bone loss. So assuring a thickness of the soft tissue, from the reasons we talked about at the beginning, we avoid the bone loss on the long run, so we have less bone loss also on the long term, which is our purpose. We don't have to treat peri-implantitis with lasers, with any other, with graftings and so on. We have to prevent it, and it is possible to prevent it. Now, when you don't have any other procedure, any other possibility, then we have to go in vertical grafting 2 times. Either you have prefabricated allogenic bones, or you have CAD/CAM milled bone parts. Nevertheless, you try to do that first, and then to do a digital planning of the implant, so at least the second surgery would be without or more minimally invasive. So we think always for the benefit of the patient. Okay. Also the bone ring, which I have also experimented, but it wasn't a subject of the case, but it's a very nice procedure simultaneously with implant placement. So with the digital planning, you can also gain the perfect aesthetic result because it's aesthetically driven, and some of the companies are working on a final abutment. Now, it is we are very much over the time. I hope that some parameters, coordinates, and some data concerning bone grafting, soft tissue grafting will be useful for you to be able to implement in your workflow in order to be able to visualize the end result of your treatment. And we try more and more to use, to be more precise in our treatments, and to use microscope, for example, which is, I think, the future also in plastic perio and in implant dentistry. And in order not to keep very much of your time anymore, I would like to thank you for your attention. And let's try that everything we do should be a quality, should be a work of art. Thank you very much for your attention. I have some questions here which I would like to read and answer, if you agree. Well, how do you manage the patient with a thin type of mucosa? Manage the patients, meaning in, I have a question, in natural dentition or implant placement. So in the thin type of mucosa, as we saw at the beginning, in a natural tooth is not necessarily an indication for treating, even only when there is a recession which is painful, which is aesthetically compromising, or it's scarious. So this is the indication to treat a recession. Now, if we have thin mucosa in implant placement, that is the whole lecture, or the half of the lecture actually is the answer to that. We use connective tissue graft when we don't, to improve the soft tissue quality, when we don't have a bony defect underneath. When we have a bony defect, we have on the market today, and this was one of my messages today, to use this membrane as to cover the grafting. The membrane should have long resorption time, non-chemically cross-linked in order not to give any infections if it's a small dehiscence, to be a matrix in order to give you also a good quality of the soft tissue. I hope you, answered the question. The second question is, do you use an allograft or xenograft for the anterior bone gap in immediate placement? Now, the qualities of xenograft or allograft are actually the same. Allograft I use xenograft or, as I said, alloplastic materials. I'm focused on synthetic materials more because I see that the industry or the technologies are able to reproduce synthetically the structure of the spongeous bone. There are differences of the beta TCP from company to company, and that's why you have to always to look what are you dealing with concerning porosity and interconnectivity. Now, when you combine it with HA, you have both. You have a bone potential, and you have also a maintenance of the volume through the HA. This is my argument for alloplastic material. I don't use allograft. I don't use xenograft, but you can use xenograft too. Now, a third question: where do you get your polylactic membrane? The polylactic membrane is a membrane which is coming from the neurosurgery. The name is sonic weld. It's used in the maxillofacial surgery for fractures or for the cranium of the babies, and is implemented in dentistry. What is your normal healing time after implant using mucoderm, and when do you have them return to final restoration? Implant using mucoderm. Well, the healing time is always depending on the implant healing. That means my opinion is when you do grafting and also in soft bone, you cannot fool the bone. You need 6 months. When you leave it in the lower bone, in the lower jaw, only 4 months, is because you have a primary stability from the insertion too. But in order to have a full bone regeneration, you need 6 months. And this is my guide. It's not about the membrane. Mucoderm needs also 6 months to at least to regenerate, and after 6 months I go for final restoration, modeling that tissue, not in between. I don't change the provisional also in the meantime of the healing, because I have implants very many times, as you saw, 85% of immediate placement and immediate loading. So I don't remove that. I don't risk anything, even if you could after 3 months. But I don't change that. I have one design at a time of placement, and after the healing, after the osseointegration, I go for the final restoration, and this is the time when I model, I sculpt the tissues which are already mature. Okay, how long will it take for mucoderm to get resorbed when combined with bone graft materials? That doesn't depend on the bone material which you use underneath. The mucoderm is healing time is also beginning with 6 months to 12 months. So this is the answer. I hope I managed to satisfy your questions. And if you don't have any other questions, I want to thank you for your patience and for your understanding, and I wish you a great evening and good luck in everything you do. Bye. Thank you, botiss.
Thank you very much, Dr. Lerner, for sharing your lecture and your insightful information with us. We'd also like to thank botiss for making this online course possible. And thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You'll receive an email notification with a link to the recording. Further questions for Dr. Lerner may be submitted directly on the website, on the courses page, under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Lerner will be sure to get back to you as soon as possible. Please be sure to visit the botiss educational platform, www.botissacademy.com, and keep an eye out for our growing schedule of online courses. Thank you again to all. Take care and goodbye.